Welcome to Pikeville Medical Center's Health Talk. Today we will be discussing interventional radiology, and we will have the opportunity to meet Pikeville Medical Center's new interventional radiologist, Dr. Hunter Boschel. We will learn what an interventional radiologist is and many of the procedures he brings to the hospital and our community. Do you have health concerns that Dr. Boschel can help you with? Or perhaps you have family members or friends who can benefit from Dr. Boschel's services. These questions and many more will be covered in today's program. But first, let's find out a little about our doctor.
My name is Hunter Boschel. I'm an interventional radiologist, originally from just outside Huntington, West Virginia, in a town called Cerrito Canova. Did my med school in Huntington at Marshall University, internship at Marshall, and then did my residency and fellowship in Cincinnati, Ohio. Since I'd completed fellowship, I spent some time at King's Daughters Hospital in Ashland and at back and forth between Cabell and St. Mary's in West Virginia. I recently started here at Pikeville Medical Center on May 1st and just getting the program up and running now.
I don't think we've had an interventional radiologist in Pikeville before. Can you explain your specialty?
Well, interventional radiology is a subspecialty of radiology. What we do, I think, probably the best way to encapsulate it in a small term is to say that we do minimally invasive procedures or image-guided procedures. We do a broad range of procedures in multiple organ systems, working with multiple other specialties. Historically, we have been more of a complement to other specialties, but as things are progressing in medicine, we're doing a lot of independent things on our own as well. Have historically done a lot of work with arteries, where you would think of a cardiologist maybe putting a stent in your heart. Interventional radiologist might put one in your leg or your kidney or your neck. We do a lot of biopsies, a lot of work with veins, a lot of work with dialysis patients, some new stuff we're getting into with cancer treatment. Again, it's a very broad specialty. Most people have not heard of it because we do work behind the scenes quite a bit in the hospital, known to other physicians but not so much to patients. We haven't had that outward face to the community, but as the specialty is changing, we're probably going to see more and more of that.
So what's the difference in an interventional radiologist and a radiologist?
The difference between an interventional radiologist and a typical radiologist or a diagnostic radiologist is that interventional radiology is a subspecialty of diagnostic radiology. In order to become an interventional radiologist, you do your medical school, you do a year of internship, and then you do 4 years of diagnostic radiology, meaning that you learn to read x-rays, CAT scans, ultrasounds, MRIs, things of that nature. During that diagnostic radiology residency, you also do some training in interventional. So you do some image-guided intervention training, typically some more basic procedures, biopsies, drainages, things of that nature. And then if you so choose to do a fellowship, you do an additional year of training in pure image-guided intervention. And what that looks like sort of depends on the institution that you're at. Some are more focused on arterial and venous work. Some are more focused on cancer treatment. The specialty is extremely varied depending on the local community and what the medical community looks like in that place.
An interventional radiologist provides peripheral arterial intervention. Can you tell us what that means?
When we talk about peripheral arterial intervention, basically what that means is that we are treating arteries in the extremities, outside of the heart and outside of the central nervous system, the brain, the neck, things like that. So most of the time what it means is we're treating arteries in the legs. Peripheral vascular disease is extremely common, particularly in our community here. It's a result of smoking is a major culprit, high cholesterol, high blood pressure. Peripheral vascular disease is caused by a plaque buildup in the arteries, calcification of the arteries, and essentially what happens is the arteries become narrow, either in a very focal place or diffusely along the artery, and the extremities are not getting adequate blood flow. Typically it's manifested by pain in the legs, particularly when walking. It can be in its more severe states, can be manifested by changes in the skin, ulceration on the feet, Lots of different ways it can show itself. What we can offer for that is historically before percutaneous intervention. When I say percutaneous, what I mean is through the skin, through a small nick in the skin rather than through an open surgical procedure. The options mostly included major vascular surgery, bypass type operations where they would make a large incision and take a graft around the area of occlusion. In the last 10 to 15 years particularly, there have been some major advancements in percutaneous techniques to treat the disease. A lot of it is performed with wires and catheters, balloons and stents, things that most of us are familiar with. You know, cardiologists going in with someone's having a heart attack, reopening the vessel, opening it with either a balloon or a stent. We do similar procedures in the legs. We're a little bit, we had been a little bit limited by length of lesion and how calcified a lesion was. However, in the last few years, there have been some significant technological advancements. We have equipment now that allows us to cross most lesions. I think here at Pikeville Medical Center, it's a really good situation because I've been able to work closely with the vascular surgeons and work with each other rather than parallel to one another. And it's just, I'm very happy with that situation. I think we've got a lot to offer the community in that aspect.
When it comes to biopsies, is there anything that you can do?
Biopsies, that's a pretty good question. We do quite a bit of biopsy work, and basically what a biopsy is taking a tissue sample. It's a fancy word for that. And historically, again, there was a lot of open surgical procedures, so that if you had a lesion on your kidney or your liver that we were curious about, didn't know what it was, and needed a piece of, a surgeon would have to take you to the operating room and make a major incision to get a piece of the tissue. However, as an interventional radiologist, what we can do is we use image guidance, typically either ultrasound or CAT scan. And we'll either use the ultrasound or the CAT scan to identify the lesion, make a very small nick in the skin, usually less than 1/4 of an inch, use local numbing medicine. It's kind of like Novocaine at the dentist. And we take a small needle, place into the lesion, and are able to take samples of tissue out. Again, the incision is about the size of maybe 1/4 inch, and the samples are usually adequate. We have them evaluated by the pathologist prior to finishing the procedure to make sure that there's going to be enough. And these are typically outpatient procedures. I would say over 95% of the biopsy procedures that we do are outpatient procedures. They have very low complication rates. You know, obviously, anytime you break the skin, poke a hole in something, you do run a small risk of bleeding or infection, but those rates are typically in the single-digit percentage, maybe in the like 1 to 2, maybe 3% range that we've seen. So, obviously, if you can make a 1/4 inch incision rather than a large incision, have to have general anesthesia and things like that, you're running into a lot less complications, and it's just a lot easier for the patients.
I understand you provide treatment for arteries. What about aortic aneurysms?
We do have treatment options for aortic aneurysms, similar in some ways to the peripheral arterial disease that we talked about. The aorta, you can think of it just as a very large artery that is in the abdomen. A common complication or a common disease of the aorta is what they call aneurysm, or abnormal dilation of the aneurysm, or abnormal dilation of the aorta, which is typically a result of the same factors that cause the peripheral arterial disease. There's a weakening in the wall which causes it to dilate. Now, once that dilates past a certain point, the risk of it rupturing becomes relatively high, and the risk of intervention is lower at that point. Historically, again, this was a major open procedure. You had an incision essentially from just below your rib cage through your lower abdomen. All of your intestines and organs would have to be displaced to get to the aorta and do a major bypass operation. In the last few years, we've made huge advancements in percutaneous treatment, and we're able to treat the aneurysms with what's called a covered stent, or it's a metal tube that's covered with PTFE or another material which excludes the aneurysm sac from the circulation. We're able to go in through the arteries in the groin, again, typically like a heart cath or our other peripheral arterial interventions. We've always had, up until the last little bit, had to make what we call a cut down or a 2 or 3 inch incision to get to the artery because of the size of the delivery system. But most grafts now are down to where you only have to do one of those, and in the near future we're going to be down to not doing any cut downs at all, but being able to do it all percutaneously through 2 small incisions, probably less than a ½ an inch. The data on aortic aneurysm treatment with the endovascular therapy as opposed to open is very, very good. It's the treatment is equivalent, if not better, than open treatment with significantly less complications and less morbidity and mortality. Patients usually spend not more than a couple days in the hospital. Patients will come into the hospital the morning of the procedure, have their procedure, sometimes stay just one night, and then go home. And then we're able to follow those patients with CAT scans. Usually we have one in about a month, one in about 6 months, and then yearly afterwards to monitor the progress of the patient. If there was to become a problem, typically those things can also be fixed percutaneously without having to become open.
Is there a connection between interventional radiology and cancer treatment?
We actually do quite a bit of work with the oncologist. As I talked about briefly a little before, biopsies, we're doing a lot of biopsies for them. We're actually able to get to a lot of lesions that typically would not be able to be accessed because of advances in imaging. But beyond that, there are quite a few things we're doing now. It's a very it's a field in interventional radiology that is rapidly progressing. We're doing several local ablative therapies, and what I mean by that is there's a couple of technologies, one called cryoablation and one called radiofrequency ablation. And what we do with that is if you have a lesion that's amenable, say you've got a couple of spots of cancer in your liver that have spread from somewhere else, typically the colon is a very common scenario, and they're able to remove the primary cancer from the colon, and there are 2 or 3 spots that are relatively small in the liver. What we can do is we can place you again in the CAT scanner or with the ultrasound machine and locate these lesions, place a special needle into the lesion which has prongs that come out into the lesion, and then either with the radiofrequency ablation we're able to burn the lesion, or with cryoablation we're able to freeze the lesion. And again, what this avoids is a major open surgical procedure, or in the case of liver, partial liver resection, or in the case of a kidney, historically they may have had to take your whole kidney out, and now we can simply burn out the lesion. There are other emerging technologies that we're doing with what we call radioembolization or chemoembolization. This is primarily focused on the liver right now. And what we're doing is we go in through the artery in the groin, much like a lot of our other procedures, and we use a small catheter, which is a small tube and wire, to select out the artery in the liver that's feeding a particular tumor. Once we've got the catheter in the region of the tumor and have identified that the artery is indeed feeding that tumor, we inject thousands and thousands of tiny microscopic beads. They're like a plastic resin, and they can either be coated with really high-dose chemotherapy or a material called yttrium-90, which is a very, very radioactive material. Now, the advantage of this is that you're injecting these things directly into the tumor, because the chemotherapeutic agents could not be taken systemically because they would be too toxic for your body to handle. And the radioactive material, the yttrium, is very radioactive. However, it only travels over about 1 centimeter or 2 in tissue. So it's only affecting the tissue locally. Seen really good results with this in the inappropriate patients. It's not a procedure that's for everybody that has cancer in their liver, but in the appropriate patients, it's given us quite a survival benefit, and in certain situations has been able to bridge a patient to liver transplant, which is essentially a curative therapy.
Many patients in our area are undergoing dialysis. Can you help them?
We actually do quite a bit of work with dialysis patients. We place dialysis catheters, whether they're temporary or permanent. A lot of work with inpatients on dialysis. We also do, we've talked about biopsies. We do kidney biopsies for the nephrologists who are monitoring patients who may be heading towards maybe heading towards dialysis. A lot of the work that we do is with patients who already have access for dialysis in the form of an AV fistula or an AV graft. And what those two are, an AV fistula is where a surgeon will go in and make an artificial connection between an artery or a vein, or artery and a vein, typically in the arm, sometimes in the leg. And what this does is it causes increased blood flow through the vein because the pressure in the artery is so much higher than the vein. And with that increased blood flow, the vein becomes dilated and makes it easy to access for dialysis. These are the most durable access options for dialysis patients. They work better than catheters because they're completely contained in the patient's body. They don't typically get infected. They typically function better. That being said, they do have problems. They are, it's a relatively delicate thing, and they can become, they can get blood clots in them and then not work. They can get narrow spots in them from where they're constantly being where they're repeatedly being accessed with needles, and we have options to treat that. Probably a very common thing that we see is a patient shows up for dialysis. The dialysis fistula doesn't work. They can't get access. They send them to me. We take a look at it and find that it's clotted. If it is clotted, we have a few options. One is that we can access it with ultrasound, and then under the fluoroscopy or the real-time X-ray, we inject dye to see exactly what's going on. If it is thrombosed or clotted, what we can do is we can inject some clot-busting medicine called TPA, or we have several devices now which are mechanical thrombectomy devices which allow us to break the clot up, reopen the fistula, and discover what the underlying problem is. Typical situation is that there's a spot in the vein that's become very narrow, and it's caused the blood flow to slow down so much that it's clotted. So once we get it back open, we're able to treat that either with a balloon or with a stent.
Is there anything you can do for compression fractures?
Compression fractures are a very common problem. What a compression fracture is, typically it occurs in older women with osteoporosis. It can also occur in cancer patients who have involvement of the bone. Compression fractures occur in the spine, in the vertebral bodies. And if you think about the spine, the vertebral bodies are basically stacked on top of one another, and they are responsible for holding all of your weight up. And as the bone becomes thin, either from osteoporosis or from cancerous involvement, it becomes weak. And when we say fracture, a lot of times we think of when we're a kid, we fall down, we break our arm, and there's a clean break across. A compression fracture is not exactly the same process. It's more of a general collapse of the bone on itself. So whereas it was a block, it starts to collapse, and essentially what's going on is there are hundreds of, if not thousands, of micro fractures or small fractures. And they become very painful because all those small fracture fragments are continually rubbing against one another, causing pain. What we can do to treat that is a procedure called a kyphoplasty or a vertebroplasty, which is essentially a fancy word for putting some cement into the vertebral body and keeping those pieces from running together. So what we do for that is the patient comes to the fluoroscopy suite, which is somewhat like an operating room, but there is fluoroscopy or real-time X-ray built into the table. We take two special needles and enter them into the vertebral body from each side. Once the needles are in there, if we're doing kyphoplasty as opposed to vertebroplasty, which is probably 95% of what we do, we place a small balloon through each of the needles, and we blow the balloon up, and what that does is it tries to give some height back to the vertebral body. It also creates a void in the vertebral body for us to put the cement in. So once we have the void, we fill it with cement, and what you typically see is that cement will start to make its way out of the void into all the small cracks in the vertebral body. Now, the really cool thing about this is that cement hardens up in about 10 to 15 minutes. And once it's hardened up, there's typically a near immediate relief of the pain that the patient's having. And there's different data out there about the effectiveness, what the numbers are, but in my own experience, I've done well over 100 of these, and I've only had 2 people who told me that they didn't get better, at least to some point. And I'd say over half, if not 2/3 of people say that they're completely better following the procedure. I usually keep people overnight just to keep an eye on them, and most of the time by the next morning they're ready to go and very, very happy with the procedure. It's one of the few things we do that provides instant gratification, and I enjoy it for that reason.
How can you help someone with spinal or muscularskeletal problems?
Patients that have spinal pain, typically very common from degenerative disc disease or arthritis in the spine, there are things that we do. We do what's called a lumbar epidural steroid injection, which is essentially a procedure that allows us to bathe the spinal nerve roots with steroid, which decreases inflammation. And the process of where you get nerve pain from the back is interesting. Typically you'll have arthritis, which causes narrowing of the canal where the nerve root comes out of the spine. And once it causes narrowing and puts pressure on the nerve root becomes inflamed and then swells, which then increases the pressure. And so it's sort of a vicious cycle there. So what we can do is, again, using the X-ray, we place a small needle into the space immediately around the spinal sac called the epidural space. We inject some steroid in to bathe the nerve roots, the idea being that the steroids will decrease the inflammation and thus decrease the compression and subsequently decrease the pain. It's an interesting procedure. For some people it works really, really well, and for some people it doesn't help a lot at all. Difficult to predict who it's going to help and who it's not, but it's a very, very minimally invasive procedure. The needle is actually smaller than what you typically get a shot or an IV with. Very, very low rate of complication. So we'll do it. Typically it seems to be worth the risk because it is very beneficial to some people. Likewise, degenerative joint disease or arthritis in the hip, in the elbow, in the shoulder can be treated similarly. We use the fluoroscopy to access the joint space, inject a small amount of contrast to prove that we're in there, and then inject the steroid. Typically these procedures, either the spinal procedure, the lumbar epidural steroid injection, is typically a series of 3 injections done about 4 to 6 weeks apart. And then the shoulder joint and the hip joint, elbows, pretty much any joint we can put some steroid in. We typically do the injection and see how the patient does. Some people it works forever, some people it works for a few months. Occasionally it doesn't work at all. So it's sort of a process that we have to work with the patients to see when the procedure needs to be repeated.
Does interventional radiology provide any assistance for pain management?
Our pain management procedures are somewhat related to actually they're typically related to the musculoskeletal procedures that we talked about, the lumbar epidural steroid injections, the hip and shoulder injections. There are a few other procedures which we can do, a little less common. Patients that have a lot of abdominal pain from cancerous involvement, we can do a procedure called a celiac plexus block, which basically we're injecting medicine into the nerve roots that feed the gut or feed the intestines that may be involved with metastatic cancer to kill the pain receptors in those. There are some more advanced joint injections, what they call facet injections or transforaminal nerve root injections that we do as well, again for spinal type pain, that are a little more advanced and not as common.
Thank you for joining us today for Health Talk. If you have questions about interventional radiology, feel free to contact Pikeville Medical Center at 606-218-3500. Dr. Boschell's office is located in Pikeville Medical Center's May Tower 1 West.